radiologist and fetal medicine specialist, Dr. Pradeep Srinivasan. Dr. Pradeep is Director of Delta Diagnostic Bengaluru, and he is ex-director of Fortis Hospital, Bangalore, India. To moderate this session, we have Dr. Ranjita Guruswamy. She is our in charge of female imaging subspecialty. She will be moderating this session. Along with Dr. Ranjita, Dr. Markova, specialist obstetric and gynecology and fetal medicine in Burjil Hospital, Abu Dhabi. She will be supporting Dr. Ranjita to moderate this session. To coordinate and to panelize this session, Dr. Yasir is there with me. He is head of the department, Burjil Hospital, Abu Dhabi. Over to you, Dr. Ranjita.
Yes, thank you, Dr. Amol. Good evening. It's a pleasure to welcome you all to today's session. We are especially fortunate to have with us truly respected expert in fetal imaging and someone I'm personally grateful to call my mentor, Dr. Pradeep Srinivasan.
Possible है तो ठीक है, अगर नहीं तो फिर मैं appointment book करवा दूँगी.
Before we begin,
Ranjita, you are muted. I think Dr. Ranjita, you are on mute.
I'm so sorry. Should I repeat again or?
Yes, proceed,
Dr. Ranjita.
Okay. Good evening, everyone. It's a pleasure to welcome you all to today's session. We are especially fortunate to have with us a truly respected expert in fetal imaging and someone I'm personally grateful to call my mentor, Dr. Pradeep Srinivasan. Before we begin, just a quick note on the topic that sets the stage for today's talk, the first trimester scan. The first trimester scan, particularly the assessment of nuchal translucency, is much more than a routine checkpoint. It's a critical window where we can identify early markers of chromosomal abnormalities, structural anomalies, and even predict certain adverse pregnancy outcomes. When done well, it combines precise technique with thoughtful interpretation, something that comes only with experience and a deep understanding of fetal medicine. And that's exactly what today's session is about, bridging knowledge with real-world practice. With that, it's my honor to invite Dr. Srinivasan to take us through this topic with his expertise and insights. Over to you, sir.
You are muted, Dr. Pradeep.
Okay, I think I'm audible now.
Yes, Dr. Pradeep.
Okay, is my screen visible, please?
Yes, yes.
Okay. Very good evening, everybody. At the outset, I thank all the organizers and especially Dr. Ranjita for connecting me to you. I fondly remember Dr. Ranjita, who has worked with me at the Fortis Hospital, Bangalore, many years ago. So the topic for today is first trimester aneuploidy markers, and we will start right away. So when I have an ensemble of pictures like this, where we have about 8 photographs or facial photographs of children, and if I put a question, can you spot the aneuploid? Then most of you would agree and immediately say that the second child in the top row is the child with aneuploidy. That's because it has a very classical and typical facial phenotypic features of the Langdon-Down syndrome. Now, when I put an ensemble of 8 pictures of faces of different abortuses, which we have encountered during our practice, and then when I ask you, can you spot the aneuploid? Then the answer would be, no, not sure. That's because we may have facial abnormalities, but we would not really know whether aneuploidy is there or not. We may have different morphological types of face, but we may not be very sure whether there is an aneuploidy or not. But now when I give you an ensemble of 6 pictures like this and ask you, can you spot the aneuploid? Then most of you would say, yes, maybe this because there is a unossified nasal bone, or this because there is a significantly thickened nuchal translucency along with an unossified nasal bone. So can we diagnose and detect genetic abnormalities and chromosomal abnormalities most of the times? That is the question we ask ourselves every time a mother walks into our office to have an ultrasound. Then the answer to it would be yes, but it is obviously a combination of a serum biochemistry, which is a blood test done from the mother, a sonography, especially one which is done between the 12th and 13th week, and of course, whenever required, DNA testing, which is by invasive testing, which could be a CVS or an amniocentesis. So it's a combination of all this which gives us a very high accuracy of trying to tell whether there is an aneuploidy in the fetus or not. Now, we have a lot of biochemical tests, which we all know, which we use during our first trimester, like the double marker test. I will not go into the biochemistry, and we will directly go into the required the knowledge which we are going to take from ultrasound today. Now we have many probes in our armamentarium when we do a scan. We have a low frequency probe, we have a middle frequency probe, and we have a high frequency probe. Now we have these probes with us, and then when we do our scan, the first image may not be great at all because the fetus may be in a very uncooperative position or probably an unfavorable position, and we may not be able to do a good job. But believe me, soon we can try to make the fetus horizontal. So basically, the first requirement we need is the uterus to become horizontal to the table or the axis or the long axis of the mother. And this can be achieved by filling the bladder. And when we do so, we will automatically be able to see that the fetus lies down. And when it lies down in a supine position, we will be able to see the midline, mid-sagittal view of the face, which we are going to achieve every time. Now, what are the differences between the different frequency probes which we commonly use? You can see that all these belong to the same fetus. And you can also see that as the frequency increases from 1-7 to 2-9 to 3-10, the higher the frequency, the better is the resolution and visibility of the facial structures, of the nasal bone, of the intracranial translucency and the NT. So the message is we need to use the highest frequency which matches the body habitus. Now this is a 1-7 probe which has been used, which is a low frequency probe, and it is a fairly good image. Now look at the 2-9 probe, which is giving a much better resolution of the face and intracranial structures and the chest. Now we have the 3-10 probe, which makes it even more crisper and even more better in analysis of the structures which we are going to soon look at. So what are the sonographic markers which can be checked at the 11 weeks to 13 weeks, 5 days, when the CRL is between 45 mm and 84 mm. The markers are the nuchal translucency, the nasal bone, the facial angle, the tricuspid Doppler, the ductus venosus Doppler, the heart rate, and obviously other structural abnormalities. So we come to the first and foremost, most significant marker of aneuploidy in the first trimester, which is called as the nuchal translucency thickness. So many times when we start the scan, it will be very disappointing, as the fetus would be deep, the uterus would be anteverted, very poor images would be there. But soon it will be possible to get an image like this, where the fetus lies down in a supine position or dorso-posterior position, and we are able to get a midline view. Once we get a midline view, then we can do a CRL measurement, which is a crown rump measurement, which has to be done when the fetus stretches itself out and when the spine becomes straight and we get the maximum dimension of the fetus from its crown to rump, which will give us the first indication of how many weeks the fetus is. Now, is it okay to measure the CRL like this? No. There is a little flexion. What happens when there is flexion? The CRL becomes a little small. The dating of the fetus becomes little less. This is an ideal view for a CRL. Now, in the first trimester, when we have a nicely supine dorsoposterior lying fetus, we can get a beautiful axial image of the fetus from the head to toe in the axial view as shown here, as we go from above below, and we will be able to look at all the parts of the fetus as accurately as what we can do at the second trimester. Now, once we achieve this, we rock the probe in a mediolateral view after the axial view, where we will be able to get a survey of the fetus in its entire anatomy, which gives us a confidence that all the parts are formed, all the limbs are formed, the proportions of the head to body and chest are normal, and then we can actually proceed. Now, what is the fetal jump? This is a fetal jump where it moves up from the lying down position on the amnion. When it moves away from the amnion, that is when you get the nuchal translucency accurately possible, because sometimes the amnion, which is behind the neck, can masquerade as the nuchal translucency. So always wait for the fetal jump, and when the fetus jumps, then decide which is amnion, which is skin of the neck, and then look at the nuchal translucency. So that's the zoomed view of the fetus, and that's the jump it takes where the skin moves away from the amnion. When the skin moves away from the amnion, then the correct nuchal translucency measurement is possible. So what is this nuchal translucency? It is simply the hypoechoic or anechoic space in the back of the neck, and it is usually measured when the CRL is between 45 and 84 mm, and it has got a very high likelihood ratio in assessing the Down syndrome. Its LR is about 6.5. So when we want to measure the nuchal translucency, the calipers used should be placed on the inner to inner aspect of the translucency. Avoid the skin and avoid the muscle plane. Take it from the inner to inner so that we get the nuchal translucency accurately. Automatic measurements are available and you can use them when the nuchal translucency is quite clear and it gives an average or mean of the nuchal translucency. But generally we prefer to get the nuchal translucency on a manual method. So when the mid-sagittal is not clear, you will be able to see a part of the maxillary bone between the nose and the palate. So this is not ideal. Now, when there is a mid-sagittal view, you can see that there is absence of the bone between the nasal bone and the palate. And this is a truly mid-sagittal view of the face, but the body is rotated. Now here, it looks like a mid-sagittal view, but you can see that in the brain, the choroid is seen and the brain is not midline. Now, when you get a true midline position, then you will be able to measure the nuchal translucency as an anechoic space as shown here. If the chin is raised away from the chest, there is hyperextension and the nuchal translucency will show a false increase in measurement. If the chin is more close to the chest wall, there is hyperflexion and this results in a reduction in nuchal translucency artificially. So the ideal view would be when the chin is neither far away from the chest or nearer to the chest and when the fetus is in a neutral position. If the fetus is lying dorso-anterior, sometimes when it does not turn at all, then you can flip the image, and then if you have a proper mid-sagittal flipped image, then you can try to get the nuchal translucency. So invert and image only if you're confident. Otherwise, it is definitely important to make the patient wait, bring her back into the room, and you will soon be able to show that the fetus is supine. Many times we see that there is a nuchal translucency which looks thickened, but when you use the color, you will show that there is a tight nuchal cord. So whenever there is a tight nuchal cord, the adjacent nuchal translucency becomes artificially thickened. So do not measure the nuchal translucency when the cord is tightly around. Wait for some time and you can see that the cord will move away and you will be able to measure it properly. So with the cord, the nuchal translucency was 3.2 mm. Without the cord, the nuchal translucency is 2.2 mm. So look at the difference. There is a significant difference when there is a cord around the neck. So avoid measuring the nuchal translucency when there is a cord around the neck. Now, whenever there is a confusion like this, where there is a skin, there is an amnion, there is a chorion, there is fluid in the nuchal translucency between the neck and amnion, between the amnion and chorion. Wait for the fetus to jump up, make sure which is the neck of the fetus, and then measure the nuchal translucency, which will give or which will not give false positive results. So now let's think that we have done all our prerequisites correctly, and then we are making sure that the nuchal translucency is increased. Now look at this fetus. When the fetus is in extension, we have an NT of 3.8 mm. When the fetus is in a neutral position, we have a nuchal translucency of 3.1 mm. So definitely the nuchal translucency increased, but do not take this measurement because it is falsely enlarged. Take this measurement because it is true measurement, as the chin is not away from the chest or close to the chest, and the fetus is in a neutral position. So considering all these factors and considering that we have a proper zoom, a proper mid-sagittal plane, and a proper picture, then measuring the nuchal translucency tells us, yes, the nuchal translucency is thickened. This is a truly positive thickened nuchal translucency. Whenever this happens, rotate the probe and you can take axial images of the nuchal translucency, and you will also be able to show that in axial view also you will be able to show that the nuchal translucency is thickened. So it is a good idea to rotate the probe and to look at the axial view and to double check that yes, the nuchal translucency increased and we are not mistaking the amnion and the skin space for an abnormal nuchal translucency. You can also see these fine septae traversing the thickened nuchal translucency, which is normal. So axial views, though we don't use for measurements in the NT time as compared to the NF time, which is done later, helps us in deciding that there is a thickened nuchal translucency. So when we have this true nuchal translucency measurements, then we can convert the measurements into percentiles, and you can show that for a particular CRL, if the measurement is more than 95th percentile, then the nuchal translucency becomes abnormal. We proceed to use this translucency thickness in a software, and we arrive at a risk for the fetus in aneuploidy. So when we have an increased nuchal translucency, then we think of the trisomies, and we also keep in mind normal fetuses, and we also make sure that there are no cardiac malformations, musculoskeletal malformations, infections, genetic syndromes, etc. We keep that in back of our mind, and then we rule out other anatomical problems and other associated abnormalities. So whenever there is an increased nuchal translucency, the chance of chromosomal defects increases, the chance of normal karyotype decreases, and the chance of an alive and well fetus also decreases. So it's a very, very significant finding which talks about chromosomal defects, karyotypes, abnormalities, and the outcomes of the fetuses. Having said about the nuchal translucency, we go to the next most important marker, which is the nasal bone. Okay, so the nasal bone is to be measured only after demonstrating three echogenic lines: the tip of the nose, the skin of the nose, and the nasal bone itself. So in a zoomed view, these are the three echogenic lines one has to observe. The tip of the nose is the first echogenic dot. The skin of the nose is the second echogenic line. The nasal bone itself is the third echogenic line. So the second and third echogenic lines give us the equal to sign. And it is only after showing the two lines we consider the deeper line which goes and meets the lower end of the frontal bone as the nasal bone. If this anatomy is not paid attention to, then it is possible to show the skin of the nose as a nasal bone and give a false positive presence of nasal bone when actually it is absent. Now, this is a cine loop showing the nasal bone, and you can see that the tip of the nose is echogenic, the skin of the nose is echogenic, and the nasal bone, which is posterior to the skin, is truly visible and bold and echogenic. So that's how we make sure that what we are actually seeing is the nasal bone and not something else. Now we have two nasal bones on either side, which are fused by a synostosis, and the nasal bone is trapezoid in shape. It is longer laterally and shorter medially. So we need to keep it as medial as possible. Okay. So in trisomy 21 fetuses, the nasal bone does not ossify. Because it does not ossify, it may not be visible or it may appear shorter. Mind you, this is a misnomer. If you use the term short nasal bone or hypoplastic nasal bone, it may be wrongly understood by the patient. So we always try to tell unossified nasal bone. And the nasal bone also has a nomogram between the 11th and 14 weeks, which we can use. However, in Asians, the nasal bone is shorter as compared to the Europeans. So absence of nasal bone, once we make sure, then we think of trisomies. And we also are aware that 2% of normal fetuses can have unossified nasal bone. So this is an example of a case where is brightly echogenic and is seen very clearly. And it's very tempting to measure this and give it as a nasal bone. But if you carefully see, the equal to sign is absent and the second line below the skin is absent. So in this case, if you measure this echogenic line, it will be wrong because the nasal bone is unossified and this is only the skin of the nose. So this is another case of an unossified nasal bone where you can see that the nasal bone is truly not visible. So when this situation happens, you rotate the probe coronally, try to show the premaxillary triangle, and you can see that these two echogenic lines are the frontonasal processes. The tip of the triangle is what is formed by the nasal bone is absent. So here we have an incomplete premaxillary triangle. The summit of the triangle is absent. So unossified nasal bone again sometimes can be very tricky because there are two nasal bones. You can see that one nasal bone is severely unossified. The other nasal bone is fragmented and mildly unossified. So we can also look at both the nasal bones by rocking the probe from the midline to the right and left. And we can also try to rotate the probe and get your coronal view, the premaxillary triangle. And then you can show that the premaxillary triangle is not complete. So you can see that on one side, the nasal bone is there. On the other side, the nasal bone is absent, and that becomes an unossified nasal bone. Whenever the CRL is small, do not proceed with the scan. Wait for a CRL to cross at least 6 centimeters. I prefer to do the scan when the CRL is between 6 and 8 centimeters and not when it is less than 6 centimeters. Sometimes nasal bone can be got very clearly by transvaginal scan. Nowadays, we do a lot of transvaginal imaging in the first trimester. So that's a nasal bone by TVS. So when it is doubtful, send the patient away, bring the patient back, and then get the nasal bone. when we have an unossified nasal bone and when the imaging is difficult, not to worry, document your findings, ask for a double marker test or an NIPT, call the patient back at 16 weeks where you can very confidently show that the unossified nasal bone is indeed correct. You can see that there is a complete loss of ossification except for an echogenic dot here. And you can see the premaxillary triangle is not seen. So what makes a nasal bone which is present invisible? Now, when the neck is extended, the nasal bone becomes parallel to the ultrasound beam. When the ultrasound beam is parallel to nasal bone, the reflecting echoes are poor, so the nasal bone is not visible. The same fetus, when it flexes, or when we move our hand towards the head and then make the beam go perpendicular to the nasal bone, it will be visible. So always remember, a good nasal bone imaging is required to be done when the fetus makes a flexion and when the ultrasound beam is perpendicular to it. So the same fetus showing no nasal bone here and yes nasal bone here, because this is extended view and this is flexed view. Wait for the flexed view to get the nasal bone. So now after the nasal bone, next we move on to the third marker, which is the tricuspid valve. Now, tricuspid valve is an important marker because it not only talks about aneuploidy, but it can also talk about cardiac defects. Now, in the first trimester, adequate zoom is required. An apical view is required when the spine should be posterior. Then we will be able to show the four-chamber view as shown here. When we have a four-chamber view like this, then you start your tricuspid valve imaging. First, make sure that there are four chambers. Identify the side of the fetus. Make sure that the apex is pointing to the left of the fetus. Then identify the tricuspid valve. After it is done, place the sample box on the tricuspid valve. Open the sample box for about 3 mm or so. Straddle the sample box on the tricuspid valve, and then you will be able to show a beautiful tricuspid valve which has two peaks. One is the E wave, one is the A wave, and that's a classical tricuspid valve. And you can see that there is no regurgitation and there is only forward flow. So when there is a regurgitation, usually you will be able to hear it as a shrill voice, and the regurgitation will be quite a bit tall in its velocity, and it will be pansystolic. So usually if the regurgitation is more than 100 centimeter per second in velocity, and if it spans the entire systole, then it's a true positive tricuspid regurgitation. And if you get a regurgitation which is not as shrill as we have seen here, which is not as tall as we have seen here, then we may be dealing with a false positive regurgitation as shown here. So in this example, you can see that the cardia is not zoomed. The sample box is not placed correctly. We have a mixture of tricuspid valve and pulmonary valve. So the regurgitant flow is not from the tricuspid valve, but it's from the pulmonary valve. And you can also see that the velocity is small. So this is a false positive tricuspid regurgitation, whereas this is a true positive regurgitation. This is again a true positive regurgitation, and this is again a true positive regurgitation. And when you do this imaging, look at the sample box. It has been open to about 3 mm, and it has been kept in a place which straddles the tricuspid valve. And we keep a part of the sample box within the atrium in order not to miss the regurgitation. Also, a point to note is most of the regurgitations are close to the septal valve. So keep the sample box as close to the crux as possible. If you are a little laterally away, you may not get the tricuspid regurgitation. So this is important in terms of where to keep the tricuspid sample box. Next, we come to ductus venosus. Now, ductus venosus is a structure which is commonly visible in the mid-sagittal plane. And if there is an A wave reversal in the ductus venosus, we may be dealing with chromosomal abnormalities and normal fetuses and also cardiac defects. Now, this is a mid-sagittal plane of the ductus venosus. That's a zoomed view of the chest and abdomen of the 13-week or 12-week fetus. And it's a mid-sagittal plane. That's the umbilical vein. This is the umbilical vein going into the portal sinus. This is the IVC. This is the hepatic vein. And now wherever I am showing you the marker is the location for ductus venosus. That's the cardia. This is the aorta, celiac axis, superior mesenteric artery, and the umbilical artery exiting outside. So in this picture, on a cine, if you have a mid-sagittal ductus venosus plane, the aliasing which comes at the end of the umbilical vein as it joins the IVC is the location for ductus venosus. So you can see this bright aliasing here, which is the point of ductus venosus, and a cine loop can clearly show the area of aliasing. So you keep your sample box as small as possible and then keep the sample box right on the aliasing, and then you will be able to get a beautiful ductus venosus waveform. Now the ductus venosus waveform has a S wave, D wave, and an A wave. So S and D are forward flows. A is the nadir which goes down. Now you can see that it is always a forward flow, and the ductus venosus will never show a reversal in a normal fetus. So this is a false positive reversal. Now, initially when the sample box was kept on the IVC and on the ductus venosus, the IVC reversal, A wave reversal, which is physiologically normal, is shown as a false positive reversal from a ductus venosus. A correction and moving of the sample box into the ductus venosus away from the IVC shows that a normal waveform is achieved. So this is a false positive ductus venosus waveform. This is a true positive. This is a normal ductus venosus waveform from the same fetus. Now, how do we identify whether a reversal in the ductus venosus is true or false? Now look at this reversal of A wave. Look at the hue of it. Isn't it bright? Now look at the ductus venosus hue. It is gray. Now hidden behind the ductus venosus is the IVC forward flow, which is again bright. So this reversal belongs to this vessel. So the reversal belongs to IVC and not to ductus venosus. So here I have shown the same phenomenon by keeping the sample box a little open on the DV and the IVC. So the IVC flow in the background, which is the short wave, has a normal A wave reversal. The ductus venosus waveform, which is gray, does not have an A wave reversal. So you can see here that this gray waveform belongs to ductus venosus. This echogenic white waveform belongs to IVC. So the reversal is echogenic, does not belong to ductus venosus. So I have drawn this on a picture. I will show it to you shortly. Now these two waveforms, you can see the ductus venosus reversal echogenicity is similar to the forward flow. Now this is TAS and this is TVS. You can see that in TVS, the ductus venosus has a complete absence of diastolic flow, and there is a A wave reversal, and the hue of the ductus venosus A wave reversal and forward S and D waves are all similar. So this is a true positive ductus venosus A wave reversal. So the first thing is to learn is to make sure that what you show is a real reversal or a false reversal. And then only we start interpreting what we are trying to show. So if we keep the sample box in the right place, if we reduce the sample box size, and if we get a proper imaging, then the reversal is a true positive reversal. And whenever we have a ductus venosus A wave reversal, then we look for aneuploidy, or we also keep in mind cardiac abnormalities. Now next we go to facial angle. Now, what is facial angle? Okay, this is also called as the frontomaxillary facial angle. So in the same mid-sagittal view of the face, we draw a line tangential to the maxilla, take it till the anterior end of the maxilla. Then we draw a line tangential to the skin of the forehead and allow that line to meet the first line. The angle subtended by these two lines is the frontomaxillary facial angle. Now, a normal fetus would have an acute frontomaxillary facial angle or an angle less than 90 degrees. Okay. Now, if the frontomaxillary facial angle is obtuse, then we are thinking of aneuploidy. The reason is when there is aneuploidy, there is maxillary hypoplasia. So the maxilla recedes, but the frontal bone stays wherever it is. So the angle increases. So an obtuse frontomaxillary facial angle is a marker for aneuploidy. Now we come to a very, very strong marker of aneuploidy, which is the nasal bone to prenasal thickness ratio. So it has two markers combined in one ratio, and this is the strongest marker for aneuploidy in first trimester. So get the mid-sagittal view, measure the nasal bone. Then from the lower end of frontal bone, draw a line perpendicular to the frontal bone till the skin of the forehead. This is the prefrontal prenasal thickness. Normally, the nasal bone will be more and the prenasal thickness will be less. So nasal bone to prenasal thickness ratio will be more than 1. Now, if there is aneuploidy, the nasal bone length will reduce, the prenasal thickness will increase. So numerator increases, denominator decreases. So what happens? The nasal bone prenasal thickness ratio decreases. So when the nasal bone nasal thickness ratio becomes less than 5th percentile, then it indicates aneuploidy. And this is supposed to be the most accurate predictor or marker of aneuploidy. So here we have a zoomed view of the nasal bone and forehead. Now this is the nasal bone length and this is the prenasal thickness. So NB by PNT ratio will be more than 1. Now if the ratio reduces, then it is abnormal. So you can see here that the nasal bone to prenasal ratio, when it is less than 5th percentile, then we know that it is abnormal. Now we also have a nasofrontal angle as a marker, but this many times is not very strong. But however, the normal nasofrontal angle is about 145 degrees. When the nasal bone becomes flat, when there is a flat face, then there is an increase in nasal bone frontonasal angle. So if the frontonasal angle is more than 145, then we consider it as a marker for a flat face or a mid-facial hypoplasia, which also could be a marker for trisomy 21. Next, we come to intracranial translucency. Now, we call it as a double line sign. In our mid-sagittal view, look at the posterior fossa. You will have 2 echogenic lines and 3 lucencies. So 1, 2, 3 lucency, 1, 2, 2 echogenic lines. So the first lucency is the pons. The second lucency is the fourth ventricle. The third lucency is the cisterna magna. Now in an axial view, also we can see the double line sign, 3 lucencies, 2 lines. This is called as a double line sign. So whenever you look at your mid-sagittal face, after finishing the nasal bone, the palate, the chin, the NT, then we come into the posterior fossa. The first lucency is the pons. The second lucency is the fourth ventricle. The third lucency is the cisterna magna. In between, we have 2 echogenic lines. So the vertical height between the 2 echogenic lines is the fourth ventricle. And in the first trimester, this is called as the intracranial translucency. When we have this intracranial translucency, we can also do what is called as a BS-BO ratio. BS is brainstem height. BSOB is brainstem to occipital bone height. So this BS length to BSOB length is called BS-BOB ratio. Now this ratio will get altered when there is an open neural tube defect, which will again cause an alteration in the intracranial translucency. Now this is the axial view showing the double line sign. This is the sagittal view showing the double line sign. And it's extremely important to show double line sign in order not to miss the open neural tube defect marker. Now, in an axial view, you can see the double line sign. 1, 2, 3 lucencies, 1, 2 lines. So this is a cine loop of the double line sign. Now look at this picture. Instead of 3 lucencies, there are only 2 lucencies. Instead of 2 lines, there is only 1 line. So this is called single line sign. Now, when there is a single line sign, the intracranial translucency is not measurable. So the IT is lost. When the IT is lost, it means there will be an open neural tube defect and the pressure or downward displacement of the posterior fossa into the upper spine causes a pressure on the fourth ventricle and it yields and collapses. Also, what happens? The BS-BO ratio increases because the brainstem increases in thickness. The brainstem to occipital distance decreases. So BS-BO ratio becomes more than 1. So that is the significance of a single line sign. Okay. So this is the cine loop showing a double line sign. That's the first line, that's the second line, and that's the intracranial translucency. So we have nomograms for the intracranial translucency, which one can refer to. This is the BS-BO ratio, which we were talking about. So that's the brainstem, that's the intracranial translucency, and then you can measure the brainstem height, vertical height, the brainstem to occipital distance, and then the ratio normally is less than 1, and in open neural tube defect, it becomes more than 1. Next, we come to the we have finished that. So now we come to important landmarks, which we have to look at in a mid-sagittal plane of the face. Now that's the skin of the nose, that's the nasal bone, it's the palate, that's the midbrain, this is the pons, that's the fourth ventricle, that's the cisterna magna, this is the occipital bone, that's the nuchal translucency, this is the skin, and that's the amnion. So all put together, we have what is called as rule of 9. And here we have a line diagram for the beginners. Look at the skin of the nose, the nasal bone, the palate, the midbrain, the pons, the fourth ventricle, the cisterna magna, the occiput, the nuchal translucency, the skin, the amniotic fluid, and the amnion. So the same thing in the mid-sagittal view of the fetus in ultrasound and on a line diagram. Now, these are the ideal pictures which have to be obtained, and there is no excuse for not obtaining this picture. If you are performing a first trimester scan, then getting a picture like this is a must in every fetus, and this will help us rule out multiple abnormalities in the fetal phase, and also will help us in ruling out multiple, making sure that the markers of aneuploidy are normal. Coming to the next marker, we have the heart rate. So when we do the tricuspid Doppler, then we automatically can get the heart rate. If the heart rate is more than 180 beats per minute, then we call it tachycardia. When there is tachycardia, then we have to raise a possibility of Patau syndrome. So keep in mind that a high heart rate is important in detection of trisomy 13. And many times this can be used to distinguish between trisomy 18 and 13. And Otherwise, both of them will show increased NT and decreased beta HCG and PAPI. So look at the heart rate, which will favor tachycardia will favor Pataus over an Edwards when we have an abnormality. Now we come to some extra points which we can see in the images which we have obtained. So in the axial image, we can actually see the aqueduct and we can see the mesencephalon. So this echogenic line which you see here is the mesencephalon, and you will have the aqueduct here. And this echogenic structure is the occiput. So it is easy to measure the mesencephalon occipital distance. And if the mesencephalon occipital distance reduces below the 5th percentile, then it becomes a marker for open spina bifida. So mesencephalon occipital distance is again another marker for ONTD. Next, we come to maxillo-occipital line. Now, in our mid-sagittal plane, draw a line tangential to the maxilla and take it back up to the occiput. Now, look at where the midbrain brainstem junction is. Now, this is thalamus. That's the midbrain. Okay. So the junction of the midbrain to brainstem will be usually above this maxillo-occipital line. Okay. So I repeat, the maxillo-occipital line can be drawn as shown here. And then the junction of the midbrain to brainstem will be above the maxillo-occipital line. Now, if the maxillo-occipital line is drawn and you find that the junction of the midbrain to the brainstem is below the maxillo-occipital line as shown here, then it becomes a marker for ONTD. Look at this picture. There is a single line sign. There is an alteration of BS-BO ratio, and there is a descent of the posterior fossa, resulting in the junction of the brainstem to midbrain to go below the maxillo-occipital line. So this is another marker for open neural tube defect. So you can see here that the maxillo-occipital line actually shows that the midbrain to brainstem junction is either at the level or above. And if it goes below, then it becomes a marker for brainstem junction. So with that, we come to a end of this lecture on first trimester markers. So to summarize, we started with the CRL, the ideal view for doing this scan, the zoomed mid-sagittal view of the face and upper chest as given by Fetal Medicine Foundation. Then the markers which we saw were the nuchal translucency, the nasal bone, the ductus venosus, the tricuspid valve. Then we went into frontomaxillary facial angle, nasofrontal angle. Then we looked at intracranial translucency. We saw what is BS-BOB ratio. Before that, we looked at the nasal bone to prenasal thickness ratio. Then we looked at posterior fossa, where we looked at double line sign. Then we looked at BS-BO ratio. Then we came into the mesencephalon occipital distance measurement. Then we looked at the maxillo-occipital distance. And then we looked at the heart rate as a marker. And finally, all put together is what we can achieve while we do a good first trimester scan. And all these markers put together can give us a strong suspicion on aneuploidy. So whenever we have a marker, then we use the marker in a software. And in the software, the other considerations are maternal age, maternal ethnicity, then the CRL, then all the markers which you can put into the software. And this will analyze with the above given parameters and the age of the patient. It will derive a risk for aneuploidy. Now, this risk for aneuploidy can be stratified into high risk, intermediate risk and low risk. When the ratio or the risk is more than 1 in 1,000, it is a low risk for aneuploidy. If it is higher than 1 in 250, then it is high risk. If the risk is between 1 in 250 and 1 in 1,000, we call it intermediate risk. Now, if we get a low risk scenario, then we don't do anything. We can ask for a double marker test and move to a TIFA scan at 18 weeks. Now, if we get a high risk, that is, if it is more than 1 in 250 for Down syndrome, we can proceed directly with a chorion-villus sampling. If for any reason invasive testing cannot be done, we can offer an NIPT, look at the NIPT result, and then decide. If we have a risk which is intermediate, that is 1 in 250 to 1 in 1,000, then we can proceed with a NIPT, get the result in 10 days, plan a 16 weeks early TIFA scan, look at the markers again at 16 weeks, look at other structural abnormalities at 16 weeks, and based on the findings at 16 weeks, decide, and based on the inputs of the NIPT, decide for an amniocentesis at that point of time, or proceed with a TIFA scan at 18 weeks. Thank you very much for patient listening. The forum is open for questions and discussion.
Thank you, sir. Thank you very much for this informative, insightful lecture. Now I would request our maternal fetal medicine consultant, Dr. Markova, for her inputs.
Thank you so much, Dr. Ranjita and Dr. Pradeep. We, in the fetal medicine department, we perform all the markers that Dr. Pradeep mentioned, and we calculate the risk based on Fetal Medicine Foundation first trimester screening. And based on that, we counsel the patient, and obviously if the risk is high, we offer CVS, and if the risk is low, we perform an anomaly scan at slightly later, most probably around 20 weeks. But I do agree with everything that Dr. Pradeep says, and we do that in our department in Burjville Hospital. I think it's better to open the forum for discussion, because maybe there will be many questions from the audience, so we can answer these questions. Thank you so much.
Thank you very much.
Thank you, Dr. Pradeep. Thank you, Dr. Markova. Now we have a time to our colleague for raising any question or the discussion to Dr. Pradeep or Dr. Markova.
So Dr. Markova was mentioning that you do the anomaly scan a little later at 20 weeks. The practice here is we have preponed it to about 18 weeks. Whenever we have a finding in first trimester, we do the TIFA scan at 16 weeks in order for an early pickup, so that we have enough time to proceed with amniocentesis. And even otherwise, even if the fetus is normal at the 12th week, our timing for TIFA scan is 18th week, which we call as the first TIFA. And then we repeat a TIFA scan at around 22 weeks, which we call as the second TIFA.
Right. Thank you so much. I mean, that will be the best option. Unfortunately, due to insurance issues, we do not have the options to do 2 level scans, one at 18 and one at 20 weeks. Yes. That's why we prefer to do it slightly later.
I understand.
That's the only reason. Otherwise, obviously, if we have any abnormal anti-scan, we do see the patient early at 16 weeks, but then it's justifiable. Otherwise, that's why we do it a little bit later. Otherwise, the optimum variant will be 18 weeks, which is early detection of structural abnormalities, and obviously amniocentesis if needed.
Agree with you, doctor.
Any question from our colleague?
Sorry, I have one comment. I think For obese patient and patient who have
Yes.
multiple surgery, when you do it early, visibility is too much not good. And if you miss anything, maybe you will be criticized. That's why I prefer honestly to make it little bit
Yes.
later.
Later. Understood, doctor. Yeah.
I think there is one question in chat, I believe.
You can read it out, doctor.
Yeah. So Madhu is asking this question, sir, on axial, if the increased NT that we saw on SAG is not seen, does it mean it's not increased NT?
Okay. So the reason why we have to confirm with axial is sometimes beginners and those who are not aware measure the space between the neck and the amnion as NT. This is quite commonly happened when we get second opinions or when we get patients for CVS, and when we do the scans, we see that the NT is normal. But then when we see the pictures done by them, we see that they have measured a thicker NT. Then we realize that yes, they have measured the space between the skin and the amnion rather than the true NT. This can be avoided by rotating and looking at the axials. So if you are not able to show a thickened NT in axial, then yes, there is doubt that you may not have measured it properly in sagittal. A true thickened NT should be seen in both mid-sagittal plane and in axial plane. It is not possible that you will not show it in axial plane. If you cannot show it in axial plane, then there is some error which you have done in your mid-sagittal plane.
Thank you, Dr. Pradeep. There is second question, which is again Madhu is asking, sir, what is the normal frontomaxillary angle? That is first part, and the normal frontonasal angle in first trimester. That is second part.
So the frontomaxillary facial angle, it's called FMF angle. The normal is about 85 degrees or so. And when it increases more than 95 degrees, then we call it aneuploidy. So this is the first part. Next, the normal frontonasal angle is usually more than 140. The cutoff is about 135. So when the frontomaxillary facial angle increases to more than 140, then that means there is a mid-facial hypoplasia or flat face, and then it could be a Downs or it could be a Binders.
Thank you, Dr. Pradeep. Dr. Pradeep, if we want to do only one aneuploidy on urgent basis, which marker you will suggest to assess in a fetus?
Sir, I understood your question, but it should not be considered like that at all, because if we are doing a first trimester scan, we have to do all the markers because the markers are visible in the same picture where both the nasal bone and NT are visible in the same picture. So these two markers are definitely to be done. If I have to answer your question strictly, among the four markers NT, NB, DV, and TV, yes, NT and NB should not be missed.
Okay, thank you.
Yes, Dr. Avinash, please.
Yeah, hi. Good evening, everyone, and thank you, Dr. Pradeep, for this excellent lecture. I have one question. If the fetus is more than 84
Yeah.
mm and more than 14 weeks, so how do you deal with this?
Yeah. So basically, let's consider two scenarios. The first scenario, it is just beyond 84 mm. That means, let's say it is 85 mm. Okay. So what prevents you from doing your scan? Nothing. So you proceed like how you would do an NT scan completely, do everything. But the issue will be once the CRL is more than 85, you will not be able to use the software. So you will not be arriving at a risk. Okay. That is the first thing. Second is, instead of calling the nuchal translucency as NT, you will have to call it as NF. So these are the only two changes which happen. Otherwise, the entire fetus would be imaged in the same way as we image the fetus when the CRL was less than 84. So this is first scenario. Second scenario, let's say the NT is more than 100. So it is about 15 weeks or probably close to 16 weeks. Then we inform the patient that they have come very late. We convert the NT scan to an early TIFA scan. We perform the entire early TIFA scan and we give the nuchal fold thickness. We tell them that we will not be able to do either a double marker test or a risk assessment. And we will make sure that we do not miss out any structural abnormalities and markers like how we do in the NT scan. We release a report with all these things and wait for the fetus to cross 17 weeks. Once the fetus crosses 17 weeks, we offer a quadruple marker test. Or if they are affordable, we ask them to go for an NIPT. And then we call them back at 18 weeks for an early TIFA scan.
Thank you very much. Yeah.
There is one more question in chat.
Yeah.
I will just read. What is the lowest normal measurement of nasal bone in NT scan?
Okay, a very good question, because there are two schools of thought. One school of thought is only the nasal bone visibility with a strong echogenic line is enough to call it normal. The second school of thought is not enough, but you need to measure also. So we believe that not only visibility of the nasal bone, but also measurement gives us more accuracy. So at a 13-week or at the window period which we have between 11 and 13 weeks, 5 days, up to 12 weeks, I don't think any of us should be doing the NT scan or first trimester scan at all, because it gives us a very suboptimal picture. So we prefer to do it between 12 weeks, 3 days to 13 weeks, 3 days. At this window period, a minimum of 2 mm of nasal bone without interruption or fragmentation, and making sure that the nasal bone base touches the lower end of frontal bone is what we consider as a well ossified bone. And we can rock the probe across the midline to make sure that both nasal bones are well ossified. Rotate the probe and get the premaxillary triangle to demonstrate that the summit of the triangle on either sides is present, so that we not only show that one nasal bone is ossified, we are able to show that both nasal bones are ossified in the premaxillary triangle, and a minimum of 2 mm is present at our 13-week scan.
Thank you, Dr. Pradeep. Thank you.
Any more question? I think we can close the session now.
Yes, sir. I think there are no more questions.
Okay. Thank you, Dr. Pradeep, for this insightful session. Your expertise and your presentation, practical guide, let this presentation and this lecture highly valuable. On behalf of me or all attendants, highly appreciating your effort and your time to conducting this valued lecture, which will helping and guide our colleague in their brackets in this little bit difficult and essential topic. Thank you, Dr. Markova, for joining us and directing this session also. Thank you, Dr. Ranjita, for organizing and make the connection with Dr. Pradeep. Thank you for all. Meet you in the next session in the next months. Thank you. Thank you, Dr. Amol. Thank you for all.
Thank you very much, everyone.
Thank you.
Thank you. Thank you, Dr. Pradeep.
Thank you.